Serious and potentially fatal adverse events included myelodysplastic syndrome, acute myeloid leukemia. Monitor patients for hematological toxicity at baseline and monthly thereafter. Discontinue if MDS-AML is confirmed. Pneumonitis. Interrupt treatment if pneumonitis is suspected. Discontinue if confirmed. Venous thromboembolism, VTE, including severe or fatal pulmonary embolism, PE. Monitor patients for signs and symptoms of venous thrombosis and PE. Advise patients of the potential risk of embryo-fetal toxicity and to use effective contraception. Please see important safety information later in this video. LYNPARZA has 2 approved indications in the first-line maintenance setting in advanced ovarian cancer. LYNPARZA is indicated for the maintenance treatment of adult patients with deleterious or suspected deleterious germline or somatic BRCA-mutated advanced ovarian cancer who are in complete or partial response to first-line platinum-based chemotherapy. LYNPARZA is also indicated in combination with bevacizumab for maintenance treatment of adult patients with advanced ovarian cancer who are in complete or partial response to first-line platinum-based chemotherapy and whose cancer is associated with HRD-positive status defined by either a BRCA mutation and/or genomic instability. For both indications, select patients for therapy based on an FDA-approved companion diagnostic for LYNPARZA.
Hello, my name is Czel. I'm a nurse practitioner. Welcome to this video series on managing some of the most common adverse events associated with LYNPARZA.
And my name is Courtney. I'm also a nurse practitioner. In our experience working with gynecologic oncology patients, we've seen many patients treated with LYNPARZA, and one of the most common adverse reactions these patients experienced is fatigue. In this video, we will be discussing some management strategies for fatigue when treating with LYNPARZA. First, let's look at some of the data reported in clinical trials. In PAOLA-1, patients were randomized to receive LYNPARZA in combination with bevacizumab or placebo plus bevacizumab as maintenance therapy after complete or partial response to first-line platinum-based chemotherapy and bevacizumab. The most common adverse reactions in patients receiving LYNPARZA and bevacizumab in PAOLA-1 were fatigue, gastrointestinal effects such as nausea and vomiting, and blood disorders, particularly anemia. There were also some more serious adverse reactions, including hypertension and venous thromboembolic events, as seen on the right side of the screen. But today, we will specifically focus our attention on fatigue. In this trial, fatigue occurred in 53% of the patients in the LYNPARZA plus bevacizumab arm. 5% of the patients had grade 3 or 4 fatigue. Diana, can you share some of the results from the SOLO-1 trial?
Absolutely. In the SOLO-1 trial, patients with BRCA-mutated advanced ovarian cancer were randomized to receive LYNPARZA or placebo as maintenance therapy after achieving complete or partial response to first-line platinum-based chemotherapy. Here, we can see that in the SOLO-1 trial, 3 of the most common adverse reactions were nausea, fatigue, and anemia. Fatigue occurred in 67% of patients in the LYNPARZA arm, with 4% having grade 3 or 4 fatigue. Let's discuss what this means.
In clinical trials, adverse reactions are typically reported as mild, which is grade 1 or grade 2, or severe, which are denoted as grade 3 or 4. The NCI has outlined for providers how fatigue may present itself to the patients and provides direction for assessing the severity. Here, we can see that while grade 1 fatigue can be managed with rest, grades 2 and 3 fatigue limits daily living activities. With this information in mind, let's look more closely at the data on fatigue from SOLO-1 and PAOLA-1.
Here, the data related to fatigue in both the PAOLA-1 and SOLO-1 trials are shown. As we discussed previously, most cases of fatigue in these trials were grade 1 or 2, which means that these patients in the trial experienced mild fatigue. Next, let's look at the onset and duration of fatigue in SOLO-1.
Here, we can see that the median time to onset for fatigue was 22 days, while the median duration was about 3.5 months. Therefore, it is important to educate patients that they may start experiencing fatigue around 3 weeks after starting LYNPARZA and give them an idea of how long the fatigue may last. It is important to advise patients that they may potentially experience fatigue, and it's also important to make them aware that management strategies exist. It is crucial for patients to communicate with their care team about their fatigue in order to optimize fatigue prevention and management. Patients should also know that fatigue might be a sign of more serious underlying cause, such as MDS, AML, so it's important that patients communicate their fatigue to their healthcare team so that we can monitor them.
Great point, Courtney. We can also counsel patients to monitor their fatigue levels by self-assessing their ability to perform normal daily activities. To evaluate their fatigue level, I ask simple and relevant questions like, what are you able to do on a daily basis? Or how, if at all, is fatigue impacting your quality of life? I emphasize that they should communicate with me and their care team if they are experiencing increased fatigue while on treatment. Like Courtney said, patients find it reassuring if they know that there are management strategies available to help make them feel better.
It is important to evaluate whether comorbidities or other Lynparza treatment-related side effects are contributing to the patient's fatigue. It is also essential to review other potential contributing factors such as dietary insufficiency, pain, depression, or sleep disturbances.
That's true. It's also important that patients self-monitor their fatigue by evaluating their ability to perform normal daily activities such as showering, eating meals, or going for walks. Depending on their level of fatigue, we can advise how they can conserve energy by avoiding things like multitasking. Resting and taking naps also helps combat fatigue and improve symptoms. Nutritional interventions, such as increased protein intake, can also be really helpful.
It is also essential that patients do some form of physical activity even if they're experiencing fatigue. I tell my patients that physical activity is good for them even if it involves just walking across their living room a couple of times. Physical therapy or cancer rehabilitation may also be helpful for patients who are experiencing fatigue. Psychostimulants and treatments that address potential contributing factors such as pain, depression, or sleep disturbances may be prescribed to help improve their energy level as well. Patients can be referred to specialists if needed.
That's an important point, Courtney. If initial strategies do not resolve fatigue, dose interruption or reduction can be considered. As a reminder, the recommended dose of Lynparza is 300 milligrams, which is dosed as 2 150 milligram tablets taken twice daily for a total daily dose of 600 milligrams. This can be taken with or without food.
If fatigue continues to persist or is severe, we can consider reducing the dose of Lynparza. There are 2 levels of dose reductions to help mitigate adverse reactions. The initial dose reduction is from 300 milligrams down to 250 milligrams twice daily. When decreasing the dose, it's important to teach the patient that they will take one 150 milligram tablet and one 100 milligram tablet together in the morning and in the evening for a total of 500 milligrams daily. If symptoms persist despite the initial dose reduction, the second and final dose reduction is 200 milligrams twice daily, which would be 2 of the 100 milligram tablets for a total daily dose of 400 milligrams.
Treatment discontinuation may be needed if grade 2 or higher fatigue persists despite 2 dose reductions. If fatigue is found to be a symptom of a more serious issue, such as MDS, AML, Lynparza should be discontinued permanently. Next, let's summarize what we've discussed regarding the management strategies for fatigue. Prior to initiating therapy with Lynparza, it is important that we counsel patients on the different adverse reactions that they can expect and how they can be managed. We also want to inform patients that communication with their care team is central to optimal adverse reaction management. Clinically, we have found that patients who are more prepared for what to expect and are encouraged to call in early when symptoms occur are often able to stay on treatment successfully.
I couldn't agree more. Communication is essential for patients who are initiating treatment with Lynparza so that we can work together to identify potential solutions. Additional management strategies for fatigue include supportive care, dose interruption, and dose reduction. Assessing underlying causes of fatigue is also important. If MDS-AML is confirmed, LYNPARZA should be permanently discontinued. In summary, communication and proactive management are important for managing fatigue in patients receiving LYNPARZA.
Important safety information. Contraindications. There are no contraindications for LYNPARZA. Warnings and precautions. Myelodysplastic syndrome, acute myeloid leukemia, MDS-AML, occurred in approximately 1.2% of patients with various BRCAm, GBRCAm, HRR gene-mutated or HRD-positive cancers who received LYNPARZA as a single agent or as part of a combination regimen, consistent with the approved indications, and the majority of events had a fatal outcome. The median duration of therapy in patients who developed MDS-AML was approximately 2 years, ranged less than 6 months to greater than 4 years. All of these patients had previous chemotherapy with platinum agents and/or other DNA-damaging agents, including radiotherapy. In SOLO-1, patients with newly diagnosed advanced BRCAm ovarian cancer, the incidence of MDS-AML was 1.9%, 5 of 260, in patients who received LYNPARZA, and 0.8%, 1 of 130, in patients who received placebo based on an updated analysis. In PAOLA-1, of patients with newly diagnosed advanced ovarian cancer with HRD-positive status, the incidence of MDS-AML was 1.6%, 4 of 255, in patients who received LYNPARZA, and 2.3%, 3 of 131 in the control arm. In SOLO-2, patients with BRCAm platinum-sensitive relapsed ovarian cancer, the incidence of MDS-AML was 8%, 15 of 195, in patients who received LYNPARZA, and 4%, 4 of 99, in patients who received placebo. The duration of LYNPARZA treatment prior to the diagnosis of MDS-AML ranged from 0.6 years to 4.5 years. Do not start LYNPARZA until patients have recovered from hematological toxicity caused by previous chemotherapy, less than or equal to grade 1. Monitor complete blood count for cytopenia at baseline and monthly thereafter for clinically significant changes during treatment. For prolonged hematological toxicities, interrupt LYNPARZA and monitor blood count weekly until recovery. If the levels have not recovered to grade 1 or less after 4 weeks, refer the patient to a hematologist for further investigations, including bone marrow analysis and blood sample for cytogenetics. Discontinue LYNPARZA if MDS-AML is confirmed. Pneumonitis occurred in 0.8% of patients exposed to LYNPARZA monotherapy, and some cases were fatal. If patients present with new or worsening respiratory symptoms, such as dyspnea, cough, and fever, or a radiological abnormality occurs, interrupt LYNPARZA treatment and initiate prompt investigation. Discontinue LYNPARZA if pneumonitis is confirmed and treat patient appropriately. Venous thromboembolism, VTE, including severe or fatal pulmonary embolism, PE, occurred in patients treated with LYNPARZA. Monitor patients for signs and symptoms of venous thrombosis and pulmonary embolism and treat as medically appropriate, which may include long-term anticoagulation as clinically indicated. Embryo-fetal toxicity. Based on its mechanism of action and findings in animals, LYNPARZA can cause fetal harm. Verify pregnancy status in females of reproductive potential prior to initiating treatment. Females. Advise females of reproductive potential of the potential risk to a fetus and to use effective contraception during treatment and for 6 months following the last dose. Adverse reactions. First-line maintenance BRCAm advanced ovarian cancer. Most common adverse reactions, grades 1 through 4, in greater than or equal to 10% of patients who received LYNPARZA in the first-line maintenance setting for SOLO-1 were nausea 77%, fatigue 67%, abdominal pain 45%, vomiting 40%, anemia 38%, diarrhea 37%, constipation 28%, upper respiratory tract infection, influenza, nasopharyngitis, bronchitis 28%, dysgeusia 26%, decreased appetite 20%, dizziness 20%, neutropenia 17%, dyspepsia 17%, dyspnea 15%, leukopenia 13%, urinary tract infection 13%, thrombocytopenia 11%, and stomatitis 11%. Most common laboratory abnormalities, grades 1 through 4, in greater than or equal to 25% of patients who received LYNPARZA in the first-line maintenance setting for SOLO-1 were decrease in hemoglobin 87%, increase in mean corpuscular volume 87%, decrease in leukocytes 70%, decrease in lymphocytes 67%, decrease in absolute neutrophil count 51%, decrease in platelets 35%, an increase in serum creatinine 34%. Adverse reactions: first-line maintenance advanced ovarian cancer in combination with bevacizumab. Most common adverse reactions, grades 1 through 4, in greater than or equal to 10% of patients treated with LYNPARZA bevacizumab, and at a greater than or equal to 5% frequency compared to placebo bevacizumab in the first-line maintenance setting for PAOLA-1 were nausea 53%, fatigue, including asthenia 53%, anemia 41%, lymphopenia 24%, vomiting 22%, and leukopenia 18%. In addition, the most common adverse reactions, greater than or equal to 10% for patients receiving LYNPARZA bevacizumab, irrespective of the frequency compared with the placebo bevacizumab arm, were diarrhea 18%, neutropenia 18%, urinary tract infection 15%, and headache 14%. In addition, venous thromboembolism occurred more commonly in patients receiving LYNPARZA bevacizumab 5% than in those receiving placebo bevacizumab 1.9%. Most common laboratory abnormalities, grades 1 through 4, in greater than or equal to 25% of patients for LYNPARZA in combination with bevacizumab in the first-line maintenance setting for PAOLA-1 were decrease in hemoglobin 79%, decrease in lymphocytes 63%, increase in serum creatinine 61%, decrease in leukocytes 59%, decrease in absolute neutrophil count 35%, and decrease in platelets 35%. Drug interactions: anti-cancer agents. Clinical studies of LYNPARZA with other myelosuppressive anti-cancer agents, including DNA-damaging agents, indicate a potentiation and prolongation of myelosuppressive toxicity. CYP3A inhibitors. Avoid co-administration of strong or moderate CYP3A inhibitors when using LYNPARZA. If a strong or moderate CYP3A inhibitor must be co-administered, reduce the dose of LYNPARZA. Advise patients to avoid grapefruit, grapefruit juice, Czel oranges, and Czel orange juice during LYNPARZA treatment. CYP3A inducers. Avoid co-administration of strong or moderate CYP3A inducers when using LYNPARZA. Use in specific populations. Lactation. No data are available regarding the presence of olaparib in human milk, its effects on the breastfed infant or on milk production. Because of the potential for serious adverse reactions in the breastfed infant, advise a lactating woman not to breastfeed during treatment with LYNPARZA and for 1 month after receiving the final dose. Pediatric use. The safety and efficacy of LYNPARZA have not been established in pediatric patients. Hepatic impairment. No adjustment to the starting dose is required in patients with mild or moderate hepatic impairment. Child Pew classification A and B. There are no data in patients with severe hepatic impairment. Child Pew classification C. Renal impairment. No dosage modification is recommended in patients with mild renal impairment. CLCR 51 to 80 milliliters per minute estimated by Cockcroft-Gault. In patients with moderate renal impairment, CLCR 31 to 50 milliliters per minute, reduce the dose of LYNPARZA to 200 milligrams twice daily. There are no data in patients with severe renal impairment or end-stage renal disease. CLCR less than or equal to 30 milliliters per minute. Please see complete prescribing information, including medication guide, at the URL shown on the screen. You may report side effects related to AstraZeneca products at the URL shown on the screen or by calling 1-800-236-9933.
Thank you for watching this video. We hope we have provided you with useful information regarding managing fatigue that you can take back to your practice and implement with your patients who are being treated with LYNPARZA. Please join us for our other videos focusing on managing anemia and nausea and vomiting.